state. And our goal really is to get everybody prepared for this transition to Medicaid managed care. And we are led by the McSilver Institute for Poverty and Research from NYU and CASA, which is the Center on Addiction and Substance Abuse at Columbia University. And the partners in MCTAC, I'm sure you've seen this before, is CCSI in the northern part of the state, NIAPRA's IDEAS, which is the Child Study Center at the NYU School of Medicine, and ICL. And I think there's something that pops up here. Yes. So somebody's kindly put in there my areas of expertise, which is flattery, I think. But essentially, what I'm going to try to do today is help put in context the managed care changes that we're having, and some experience in terms of doing this in another state, and also leading ICL through the preparation for managed care and our experience in the last month or so in how that's going. And I think those of us downstate know that it's been incredibly complicated and full of details of which we've been struggling with like anybody else. But so we've got some results from the polls, and I think we've got some strongly agree, strongly disagree. So we've got I think a good sense that we've got a lot of learning to do around supervision in terms of managed care, and I'll try to do the best I can. Thank you for those. Thank you for those questions. I think we'll put similar ones up at the end to see if there's any improvement from listening to me for the 40 minutes or so. There are some remaining topics in this webinar series. We have one on tracking documentation to support successful communication with the utilization management staff within the MCOs. One on client education. Because in the world of utilization management, really what's changed to an enormous degree is our clients, our consumers' benefit plan, and understanding the work that we need to do in terms of a change benefit plan is important in terms of family education. In terms of client education, and we're also providing a session on family engagement. I think we're really well aware that as much as we can in terms of bringing families in to help support the work we're doing is incredibly important. And then we have a couple of applied learning discussions, case examples that help with 2 OMH and 2 OASAS specific learning discussions at a later date. So what am we trying to do today? Well, I'm trying to give an idea about supervision in the context of managed care, how our clinical supervision should adapt, and how do we use data and outcomes to help supervise. And I guess what I'm trying to get at is that overall, I think that supervision has been something that's been more of a private one-on-one task between supervisors and clinicians, and we're moving to a place where supervision needs to understand that one-on-one supervision in a broader systems context. And I'm not really saying that's instead of the one-on-one, but unfortunately, as we've had to explain, I think a lot over and over again, is this isn't instead of, this is in addition to the work that we've been doing traditionally in supervision. I think it feels chaotic at the moment, so I've tried to put together some fairly clear, simple sense of what the role of supervision is and what you need to do to be successful. And as I say, I've had some experience of this in another state, and also working here with in New York over the last few months with managed care organizations. So that's what I'm attempting to do, and we'll see if that's the case over the course of the next 40 minutes or so. So supervision in context. What I mean about this is supervision in context of your agency. From this slide shows the supervisor being in a sandwich almost between management, director level staff, and the staff and clients. And I think there's a huge role for supervisors to understand what their role is as defined by the director or the management of the agency in terms of being able to communicate that with staff and therefore successfully communicate it for staff to clients. And we do have an upcoming webinar, as I mentioned, about that work with clients. Later in this webinar, we'll be talking a bit about something about the golden thread of treatment. I think something that we're all very used to. But what I'm sort of talking about here is the golden thread of the mission of the agency through supervision, through treatment. If as supervisors, you don't understand how the agency views managed care, what its attitude towards its managed care is, and what your role is, I think it leads to a lot of confusion. It means it's very difficult for you to describe to staff why managed care is important. I think the last thing you want to be doing is in a situation where managed care utilization management feels like it's something being done to you, something that's separate and aside from treatment. I think as a supervisor, you need to understand how the work you're going to do with your managed cares and preparing your staff to work in that environment fits into the agency overall. So an example of a golden thread or a story for an agency can be that the clients that we serve, using my agency as an example, need the treatment that we provide. This isn't really safety net treatment. Substance abuse treatment, clinics, ACT, and PROS are all treatment for people with serious mental illness and substance abuse issues. And they need that treatment, and the MCOs are the vehicle for getting the treatment. So in many ways, the managed care and the utilization management is the vehicle for getting essential treatment. And I've argued over and over again to our staff that if somebody's denied treatment because of our failure to be able to provide good clinical justification and communication to a managed care companies, then we failed a client. So in that way, what we're trying to do is make the discussion and the utilization management part of treatment and beginning to understand where the clinical in managed care resides. The best place to be is when we understand that good clinical practice delivers the same outcomes that the managed care is looking for. For instance, in this at ICL, I've been sending out newsletters for probably 20 weeks that have been detailing what managed care is, what utilization management is, what the HCBS services are, and how we as an agency view that and the role of staff within that. It's been an education issue, but it's also been to try to align all staff within the agency. Without that as a supervisor, I think you'll find it very difficult to be able to justify cleanly what you're doing, the work that you're doing with the staff and with it to the clients. So as a supervisor, I would encourage you to make sure that your agency can clearly articulate that. In the same way, I'm going to be arguing that the clients, the staff that you work with should be able to clearly articulate the treatment they're providing. I hope that makes sense, but I think it's very, very important to be able to have that clear alignment of the work you're doing in supervision with a managed care company in terms of how does it fit into the mission of an agency. So maybe the most critical part of supervision and understanding how managed care works as it relates to supervision is going to be utilization management. And we're going to focus on this because it's really where the managed care rubber hits the road in terms of supervision. The slide here is one that we've used before in previous MCTAC webinars, and really outlines some of the important details around utilization management. So it's a process by which managed care companies decide, does somebody get the service, which is the first bullet. And if so, is it being provided at the right amount at the right time? If that's the case, is there quality, the fidelity and integrity of services? Are you able to provide quality? The utilization management for some of the programs that we run is simply a requirement for reimbursement. And it's really in utilization management, as we're going to be facing it, is intended to be consistent with optimal care. Are we providing the best practice? So it's important that the clinical it's important that we're beginning to understand that supervision used to be a purely internal process, but now utilizations management is going to make sure that that process that we work with internally is going to be scrutinized by managed care companies, and utilization management is going to be the vehicle for that, obviously. And in other words, to make it more simple, utilization management is really about authorizations, both pre-authorizations and continuing stay reviews, which are also known as concurrent reviews. The documentation that you provide in terms of medical necessity, best practices, evidence-based practices, the clarity of notes, progress towards goal, and that golden thread. It's also going to mean that we're going to need to understand outliers, and I'm going to come back to that in a little while. And also we're going to need outcomes and data to be able to describe what we're doing and the efficacy of what we're doing. The documentation piece in that is something that has been, as supervisors, an existing area of focus. It's something that I think we've always wanted to make sure that the staff, the clinicians in the clinics providing substance abuse treatment, in the ACT teams and in PROs have always been very clear about. The difference is, again, and I'm going to keep on coming back to this, I think, is that it's going to be scrutinized by the MCOs. Whatever's written in the notes, whatever you're working with around supervisory details in terms of the treatment plans, the progress notes and the assessments, could be reviewed by a managed care organization. And I think that's the piece that you have to keep in mind in terms of supervision. Okay, I was trying to read my notes to see if there's anything else there. But so the rest of this webinar is going to be basically looking at authorization, documentation, outliers, and the outcomes and data. So just to review, perhaps importantly, what has changed and what hasn't changed in terms of authorization, because I think we had a lot of anxiety to begin with about the level of authorization. So we know for mental health that clinics don't require authorizations, with some important exceptions. And if you don't know already, Beacon is going to be looking at people who reach the 30 mark in terms of mental health clinics. I think that what I've heard is they're pretty clear that that isn't a hard stop. It requires a discussion around why somebody needs continuing treatment. It may not be a hard stop, but if we don't call at 28, 29, we're not going to get a 31st visit paid for. So it's important that although that isn't a hard stop, it is going to be something we're going to have to discuss with Beacon. Pros and ACT, we know, are very complicated. It's complicated in terms of we don't need reviews for pre-admission, but we do for the individual recovery planning for some insurances, but not all. ACT, we need pre-authorization. The good news for substance abuse is there's no pre-authorizations or continuing stay reviews for the outpatient services. But as we know, residential will need it. And judicial mandates still override the clinical decision. So all the managed care companies are pretty clear, I understand, that somebody who has an AOT order, that is justification for treatment services. Saying all that, the point I'm trying to make is that it isn't a simple supervisory task to know, to be able to, there's not one simple rule. there's different rules for different managed care companies and different programs. And as a supervisor, we need to begin to understand what those rules are for different companies and who's enrolled in which managed care company. And again, I'm going to come back to that as we go through this. The CTAC has on its website all of the webinars that we've done already in terms of who needs which authorization requirements, utilization management. So please use those as much as you need to update on those details. So supervisory role in terms of focusing on utilization management. Again, a lot of what's on this slide is, I think, what we've been used to doing with good clinical supervision. But it's important to think about staying ahead of what the managed care companies want. So supervision becomes not only a review with a clinician in terms of are they providing good care, but also what is it that the managed care company is going to be looking for in terms of any ongoing treatment that we need to justify. Some basic things that we come across all the time in terms of, is the diagnosis accurate and do the interventions match the diagnosis? To some extent, if that's not been the case in the past, as long as treatment is satisfactory, then that sort of detail has not been picked up, but managed care companies will. Is the medical necessity there? Are the treatment goals, we use this SMART acronym, specific, measurable, attainable, realistic, and time limited, and the golden thread piece. I think all those are typical and understandable roles of supervisors. But again, I'm going to come back to the point that is going to be scrutinized by managed care companies in certain circumstances. It means that you're going to need to review all of the treatment with staff. So there cannot be cases that are not discussed between a supervisor and a supervisee. You should begin to think about how do you think about being your own internal utilization management. So how do you think, how will you justify ongoing treatment in terms of what's been presented to you in supervision to a managed care company? Does that make sense? Does the clinician able to articulate a clear treatment objective from diagnosis to treatment plan to progress notes? Can they do that with you? Because if they can't, it's unlikely they're going to be able to do that with a managed care company. So you need to be thinking as a supervisor in terms of how crisp is the treatment that's being provided, and how well does that translate to an argument with a managed care company that somebody needs ongoing treatment services. It sort of goes without saying, I think, that the treatment, the utilization management focus is going to be on individualized care, that the managed care companies are not going to be wanting to see cookie cutter approaches. They're going to want to see this golden thread for treatment assessment, goal planning, and treatment plan, as we said before. MCOs are going to look to make sure that as a clinic or as a treatment provider, there isn't a cookie cutter approach to all treatment isn't the same. However, it's also going to be important that individual treatment is also seen, and this is where we begin to think in a more contextual way. It's important that the individual treatment that's been provided is seen in terms of the overall treatment of people in similar situations in a clinic. And this is where we begin to think about outlier management. Is the treatment being provided to that individual consistent with what the clinic expects from individual therapists? Does it match people who are providing similar services? So there's a duality going on that we need to supervise, individual treatment, but we need to manage that within the overall pattern of care that we provided in the clinic for people in similar situations with similar diagnoses. And that's where we begin to think about data and outcomes and outlier management, which I'll return to in a few minutes. So other important clinical considerations. We've always talked, and I think a lot of you on the phone listening into this webinar will be wanting to use best practices and evidence-based practices. And again, this ends up being not just what seems to be the appropriate thing to do in terms of treatment, it's also what managed care companies are going to be looking for. So somebody with a certain diagnosis, a certain set of functional assessments, for instance, the managed care companies are going to have some idea about what the most effective treatment is. I mean, this is hard to argue with that we should be in a position where we are providing the best available treatment, but for some of us that's difficult when we don't have a breadth of staff to be able to provide it in the full range of treatment services. But it is something that's going to be more and more critical, is that we understand that somebody with a certain set of diagnoses, certain diagnostic criteria, and I'm thinking, for instance, maybe about somebody with PTSD. Are we providing the best evidence-based treatment for that person, or have they been in treatment for many, many years with outcomes that don't show any serious improvement over time? Those are the things that managed care companies are going to care about. Interestingly, not just we may cynically think from the money point of view, but also there's a serious interest in making sure that people are receiving the most effective treatment and getting better as quick as possible. It's also important to think about co-occurring disorders. Obviously, somebody who's receiving substance abuse treatment, are we looking at them an assessment for mental health, and vice versa? And in terms of people receiving mental health treatment, are we assessing appropriately for co-occurring substance abuse disorders? And perhaps really importantly, are we evaluating for physical health needs of people in our clinics? Because one of the perhaps the areas where most savings that the managed care is looking for in terms of savings is within the healthcare spending with people with co-occurring mental health or substance abuse issues. So again, it's going to be interesting as we work with some of the managed care companies that if we're providing mental health or substance abuse treatment and people are using a lot of physical care, it could be that the managed care companies are going to see that as an outlier, and I'll come again to that in a minute. And if we're the major provider of healthcare for somebody, why are we not addressing why are we not beginning to think about the healthcare needs of people? So for those of you who are already working in an integrated setting, you have a leg up. But for those of us that don't have integrated healthcare with mental health or substance abuse, we may need to be looking within individual treatment and individual supervision and also a clinic setting to make sure that we have access to those resources and people are being appropriately referred. Treatment plans and interventions updated when relevant information becomes new. One of the things that's interesting I've heard from managed care companies and people who've worked for managed care companies is that they're really interested in, does the treatment that we're providing match what's on the assessment and the severity of some of the details that may be hidden in old assessments or treatment notes from years ago. And one of the explanations I heard about this was if somebody has serious violence in the past, serious psychotic episodes, serious depressive or suicidal tendencies that may not have shown themselves for a number of years, the managed care companies are going to be interested to make sure that what we provide at the moment is taking into account those things, even though they may have not been present in your treatment session for the last few months or as long as you've known that client, because they're interested in making sure that somebody's historical illness or behavior or treatment patterns doesn't result in poor outcomes now. So even though it may not be something that's an immediate issue now, making sure that we understand the full diagnostic and assessment history of somebody is really important, because surprisingly, when we come to reviews that are necessary in ACT and PROS, etc., the managed care companies may be looking at those details as we have to send them through some of the the assessment details. And of course, the important issues about are the progress notes reflective of the progress towards goals, person-centered, recovery-oriented, and are we using EBTs or need to be involved in there all the time. One of the important elements as a supervisor is the ability to identify progress. One of the things I think we're going to hear most from managed care companies around, if you're talking to Beacon after 30 sessions, if you're talking to any of the MCOs around services to ACT clients, we've begun receiving for ACT clients authorizations for 90 days. 90 days is an incredibly short time for somebody on an ACT team, for instance, and proving that they need services beyond that 90 days, that there is progress, there is amelioration of symptoms is going to be very important at that. Do you have any tools to help you with that? Again, to use our experience, what we're beginning to do is introduce the DLA 20, which is a functional assessment scale that you can find reference to at from the National Council's website. We're using that specifically so we can begin to assess somebody's functional assessment over time, because without that, it's going to be very difficult for us to suggest to a managed care company that that somebody is improving over time. Now, one of the questions is if you're in an agency that doesn't have any of those tools, what are you going to do? Well, one of the things I think is important is to begin looking around for what is available. The DSM-5 in Section 3 has some tools for assessing severity around schizophrenia, psychotic illnesses, for cross-cutting symptom measures for adults, and also has an example of I love this phrase, the HUDAS-2, which is a scoring instrument provided by the World Health Organization. But again, it attempts to assess people's disability, and you can begin to use this over time. So these things, I believe, are in the public domain. So without necessarily a large amount of expenditure, it can be that there are tools out there that are going to be useful in terms of measuring somebody's functional assessment and how the treatment you're providing is helping somebody over time. It's going to be an incredibly important dialogue with managed care companies as users begin to do that. So this is going to set you up for understanding about discharge planning. If there's another element that's going to be important in supervising staff around treatment is really thinking very hard about discharge planning. Again, I think it's not unusual for us to think about discharge planning at the point of access. But again, reiterating what I've said a few times, is that there's going to be more scrutiny about this. So when we begin talking to the managed care companies around ACT services, when we talk about inpatient substance abuse services, one of the questions is, when's the discharge taking place? We've have to be able to really articulate that in terms of somebody is or isn't ready for discharge. But it is important to begin thinking as a supervisor about the fact that interventions may not be as long-term as we're used to them. Discharge is going to mean that we're going to need to know where the next level of care is for people. For a lot of our services, it may be that your agency doesn't have either a lower or a higher level of care to refer to. But that's one of the things, either as a supervisor or a program director, begin thinking about is other agencies that can provide either step or step down treatment for somebody who's with you at the moment. So for a pros team, that may be a step down to some of the HCBS services when when they're available. For a outpatient clinic, that may be a step up to a PROS program or a step up to an ACT team. If you don't have the availability, begin thinking about which other agencies you can begin to have services agreement with, referral agreements with, so you're able to facilitate those. Needs to be a constant discussion within supervision as to are people ready for, are clients ready for discharge from that program. And I think this is an important element, because an important distinction, because for the managed care companies, they're less interested in programs than they are in terms of their members' treatment. And if somebody requires a higher level of treatment than the program they're in, that is what the managed care company are interested in, that their member gets the appropriate level of treatment, not our individual programs. And this has been, I think, an important shift in all our thinking in terms of episodes of treatment rather than individual programs. So for an agency that has many services, many programs, outpatient clinics, inpatient, PROS, ACTs, inpatient treatment, and outpatient substance abuse treatment. The thinking with people's episode of care isn't necessarily just the one program, but how do they move between levels of care over time to make sure they're getting the most appropriate level of care at the right time. So rather than thinking as a supervisor about the program, thinking about people's overall episode of care and where do people fit in, and how do you assess that, and how do you get ready to move people from one treatment level to another. And if your agency doesn't have the appropriate level of care, how do you begin to advocate with your agencies for those service agreements and referral agreements with other agencies? There's another element of this in terms of if it's likely to be that lengths of stay shorten, it means that there's going to be an increased turnover in clients. And again, as a supervisor, I think there's two elements to begin to think about in terms of if there is an increase in turnover of clients, how do you begin to organize both the clinic in terms of more referrals, maybe open access, and how do you work with staff to be prepared to see people over shorter periods of time, but perhaps be dealing with people in more intense need. One of the things that longer lengths of stay often allow clinicians to do is work with people over longer periods of time. They know the client, they understand their story. But I think as we begin to increase turnover, a lot of staff are going to begin to need to see people in more intense and more acute episodes. That's going to increase stress. It's going to increase that vicarious effect on clients, and begin to think about, as a supervisor, how do you support people, seeing people who are turning over within the treatment setting more quickly. And again, if you're a supervisor in any of these programs, begin talking to the management and the administrative supervisors or directors in terms of how do we prepare ourselves for getting more clients, more people through our programs. So that's discharge planning. So as many of the managed care companies are not necessarily going to be interested in authorization and continuing stays for individual clients, particularly for outpatient services, both mental health clinics and substance abuse clinics. What a lot of the MCOs are talking about is outlier management, and this is really a thing that we need to get our heads around in terms of what does that mean for our supervision and our management of services. Outlier management is basically in that chart there, that bell curve tries to describe that the vast majority of the services we provide are within the norm in the middle. However, there are outliers both in terms of extreme, as it describes there, good value outcomes. So we're providing good treatment that provides people with good health care that returns people to recovery and to a low level of care quickly. There are also the outliers on the other end of that bell curve. So outlier management is really beginning to understand how individual, and I think I'll turn to the next slide, individual clinicians' services perform, outliers in terms of specific diagnosis, outliers necessarily in terms of program sites, and outliers potentially in terms of subpopulation characteristics. What I mean by that is that the managed care companies are going to be looking at norms of treatment, but not just in terms of individual treatment. They're also going to be looking at, do clinics overall have a pattern of treatment that is within the norm? And do clinics for certain diagnoses have treatment patterns that are within the norms? Now, to give you an example, if you've not already been contacted by Beacon, but my agency, ICL, has met with Beacon a couple of times because what they have is data on our members. They know by clinic the number of members we've seen, by age, the volume, the number of visits, the percentage of assessments we've done, who the high utilizers are, and the number of people using inpatient care. They know that not only by numbers, they know that by cost per member, the cost by the top 3% of members, and they know that comparing our agency with other agencies. So we're presented with information on our clinics in a level of detail that we didn't have ourselves. And I think it's important that everybody understands that the managed care companies, because of claims data, know more about the patterns of treatment than we do. We were lucky, or maybe I should give credit where credit's due. Our treatment in our clinics was shown to be more costly for the number of services provided by our clinic, but the number of folks using inpatient care was zero. So what Beacon could look at us and say is, we're in one way an outlier on the value because people using our clinics engage better than the average, stay longer than the average, but use less inpatient services than the average clinic. I wouldn't like to be the clinic that is the other way around, that has fewer than the average number of visits, but the clients are using inpatient care, because the conversation that we had with Beacon could be very different. Now, I raise that because if they know that, what do we need to know to be able to understand before the MCOs do what is the pattern of care within our clinics? And this is where, in terms of supervision, we need to move beyond the individual supervision into supervision within context. And really, the data that you should be tracking within a clinic or within a PROS program, within inpatient substance abuse treatment, should be data like the length of stay. What's the episode of treatment that people receive in services here? What's the frequency of visits that people who come to our clinic use? Understanding that by diagnosis. Understanding how many people who come to the clinic stay more than 2 visits. Beacon had a phrase of enrolled, I think, qualified member. So a qualified member is somebody who received more than two visits to our clinic. So they know the number of people that stay more than 2 visits. They also know the number of people who don't engage with our clinic. So as a supervisor, you need to be able to understand the episode of treatments, how frequently people are coming, the engagement rate by diagnosis, because trust me, the managed care companies do. And you need to be thinking about how do you, if that data doesn't tell you a good picture about the frequency of visits to the clinic, the PROS program, the ACT team, et cetera, how do you begin to change that? You should also be looking to think about how do you understand the outcomes of the people who are using your services. Do you know, for instance, the number of times people who use your programs are using the emergency room, both for physical and psychiatric and physical care? Do you know the number of times people are hospitalized? Do you know some of the integrated health outcomes, like do you measure blood pressures, A1C levels? Any of those outcomes that you can develop are going to be critical in terms of saying, yes, but did you know that the people who receive service on our ACT team are not using the emergency room at all? Or we prevented people from being hospitalized, from a certain rate to a lower rate. And if you're not making a difference in those things, supervision becomes the key part to say to your staff, your team, your individual clinicians, how do we begin to change these? What do we need to do for the folks that we're providing services from to improve their health outcomes? Because again, without that, it's going to be difficult to justify ongoing treatment to the managed care companies, and also where managed care is going, which is really value-based payments. Because really, in terms of the work that you're doing as a supervisor with your staff, is managed care is just the starting point. The first step in the change that we're facing at the moment is the fact that we have managed care companies who are interested in utilization management. But what we really need to be thinking about in terms of our supervision and with our staff is how do we understand the value that the value of the services we're providing. The United Hospital Fund, if you would look at their website, they've just published a document called Navigating the New York State Value-Based Payment Roadmap. And what this tells us is that over the next 3 to 5 years, Medicaid will move from a system of fee-for-service payment to a value-based payment. Really what that means is instead of paying for the number of services we provide, we will be paid depending on the value of the services we provide. And the value rather than volume is an important to think about in terms of value to who. If we're trying to work with managed care companies that they understand the value of our services, what I would like to be able to do is what I did with what Beacon presented to us, is that people engage in our treatment services. They stay within treatment, and we can prove that their health gets better because they're not using the emergency room, they're not using the hospital, their blood pressure's reduced, their A1C levels are getting better, and what we're able to do for a good value is improve people's health care. That's a very complicated place to be in terms of where we've been in the past as behavioral health specialists, but it's where we need to be in 2 or 3 years' time. So I think as I mentioned earlier on, the idea of understanding the golden thread of what we're doing in terms of your agency's mission through to treatment, understanding how the work you do at the moment with managed care companies is preparing your agency and the treatment you're providing for value-based payments is incredibly important. And if that's not part of the discussion that's taking place at the moment within your clinic, within your agency, within your clinicians, I think it's something that you should begin to understand. How does what we do today set us up ready for demonstrating value? Because in the past, just to reiterate, we got paid for the number of visits we did. And in 3 years' time, to some extent, the managed care companies or the performing providing systems are not really going to care about that. They're going to want to be able to work with us around what is the value you give. And our value to them, to a hospital, to a managed care company, is about improving health. So therefore, we're also beginning to save dollars in terms of managed care. It's the triple aim that we're always aiming for, which is improved outcomes that reduce costs with improved consumer satisfaction. I think I'm beginning to reach the end of this. I know there was some, this is just a quick note around supervising interns. I think this was raised, and I was asked to include this because interns' positions within a lot of our agencies being one of being a very protected status, and quite rightly so, except again, some of the treatment that those interns are going to be providing needs justifying to the managed care company. So this is just a note to think about supervision for interns and how that may need to adapt as well to this new environment. So to begin to recap, the role of supervisor, this is getting needs met. Do your clinicians have the support they need in terms of professional development? Do they have a basic understanding of managed care? Do they have things like scripts for discussion with managed care companies and scripts to develop with clients and how to talk about their benefits? Are we able to provide training so they're able to provide best practices, evidence-based practices? Thinking about in terms of what does somebody need, are we providing those clinicians with that support? And do you have what you need as a supervisor within an agency? Do you have a clear understanding of your role? Has the agency clearly delineated or defined for you what your role as a supervisor is in terms of managed care? Do you have the technical resources? We're again lucky enough that we invested in an electronic health record a number of years ago. But I know some agencies are going to be working without one. So there are things that we should be thinking about without the full extent or expense of an EHR. Do you have scheduling? Do you have scheduling available? Do you have spreadsheets available for tracking visits, authorizations? Do you have ways of having data that's available to you? Are you tracking outcomes? All of these things as a supervisor you're going to need to have at your fingertips, but I wonder if you're an agency that doesn't provide those in a way that's actionable, do you need to start advocating to your agency to begin providing this? Because the worst thing in the world is you want to be on the phone to a managed care company that knows more about the client that you're serving, knows more about the pattern of treatment within your clinic than you do. You need to be armed with data, information, and how the treatment that you're providing for the individual you're discussing fits into the norm within your clinic and perhaps within treatment generally. So I'll summarize. Managed care and utilization management is changing how you support your clinicians. You should think about being internal auditors, ensuring the medical necessity and the quality documentation is part of the treatment plan before speaking to the MCO. Make sure that you're able to clearly articulate what's going on, and that should be a day-to-day part of supervision. Being able to understand very clearly what's happening to somebody's treatment. And it should be done in the context of your organization. So leadership, supervisors, and clinicians are all on the same page in terms of your role within managed care. The worst thing I think is that if you're confused, explaining that to a staff member about why we need to deal with managed care companies is going to trickle down to the client, who's going to be confused and not understand why managed care is taking an interest in their treatment. So understanding that golden thread from mission through to actual treatment is very important. So in terms of next steps for you as a supervisor, I'd really be wanting to understand your team's caseload. Who's on it? What's the insurance company for each of those folks? What's the diagnosis? What's the general pattern of treatment? How long are people in service? Make sure you have a calendar for reauthorizations. Those authorizations for lots of services are going to begin to run out, and if you call on the 32nd visit for Beacon, the 2 previous ones are not going to be paid for. It's important that we get ahead of that, but somebody needs to have a tickler for you to be able to manage that. Make sure that the charts, the notes have quality, medical necessity, and make sure there's an organizational plan for who speaks with the MCO. While I'm speaking, if you could go back to those poll questions, I'd appreciate it, and they're open now for a minute or two. But make sure there's an organizational plan for who speaks to the managed care companies, so they're trained, they understand what to do, how to speak, who they're going to speak to. Because in January, I think I'm accurate in saying that all the folks who are enrolled in ACT teams and PROS programs, at least, and probably in patient substance care, are all going to need authorizations for continuing stay. The 90-day window closes in January. It's one of the things I think, you know, I know we need to do better as an agency is prepare for that, because we're going to have a lot of people calling managed care companies in January. Make sure you're organized for that for the next step. And the next webinars that we have, tracking and documentation in December 8th, and applied learning discussion. This is an OASAS 1 at noon and OMH at 1 on December 15th. Are the next steps in terms of what we're providing treatment in terms of the webinars. So I hope that was in some way helpful in terms of thinking through supervision and moving away from an individualized work with clinicians, and thinking about your clinicians and your treatment in the context of treatment patterns and what you may need to have at your fingertips to be able to talk to the managed care companies, but also talk to their clinicians about their treatment and how their treatment can better provide good outcomes in as efficient way as possible, because that's what managed care is about and that's what we're facing. So thank you. I hope this has been helpful. And what do I need to do now? So we're getting some reviews from the questions. Oh, okay, sorry. So here we go. Please email any questions. Yes, so we have the December 15th. We have the webinars, and if you've got any questions, please email them to mctac.info@nyu.edu, and we'll try and answer those as we receive them. Thank you. Thank you for your time.